I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
This is a 73-year-old male, former smoker, greater than 30-pack years, with newly diagnosed squamous cell lung cancer of the left upper lobe, potentially stage 4, with FDG-avid left thyroid lobe nodule and right intraparotid lymph nodes. We'll talk about potentially some staging for this patient. The ECOG performance status of 2 to 3. And the question that we'll try to answer at the end of this case is, what are the recommendations from everyone in terms of next steps for treatment? So just a patient presentation, pertinent positives, again, a 70-year-old gentleman with an ECOG 2 to 3 who presents with cough, shortness of breath, left-sided chest pain, and weight loss of more than 20 pounds. He has a past medical history of type 2 diabetes, coronary artery disease with a history of a cabbage. He does have significant history of tobacco use, which may explain the histology here, but no alcohol or drug use. And he has no significant family history as it relates to malignancies. So we don't have imaging on this case, but I will review what at least the read was for his chest X-ray, his chest CT, and his PET scan. So the chest X-ray after this presentation revealed a large cavitary mass in the left apex, and this was followed by a chest CT that revealed a 8.3 by 7 centimeter left upper lobe necrotic mass that abutted the left major pulmonary fissure, did not extend across it, and it involved the pleura close to the left posterior lateral ribs. There was no cortical erosion seen and no clearly separable from the intercostal muscles. There was no contralateral pulmonary nodules noted. There was an enlarged ipsilateral hilar lymph node that measured 1 by 1 centimeter. There were some sub-centimeter subcarinal left retroclavicular lymph nodes. No contralateral, no right hilar nodal noted, and the provisional staging was a T4N1M0. His CT abdomen revealed no evidence of metastatic disease. So again, a large upper lobe mass, 8 centimeters, with ipsilateral nodal disease on the CT. The PET scan is done that confirms this left upper lobe mass, roughly 9 centimeters with an SUV of 6. He has some left hilar lymph nodes, SUV of 1.4, has some right intraparotid lymph nodes. Maybe we can talk about the chances that this type of lymph node may be metastatic. It's 1.2 by 0.8. The SUV is 4.9. He does also have some lymph nodes beneath his right sternocleidomastoid muscle. We don't have the size, but the SUV is 3.2. And then a left lobe of the thyroid gland with underlying cystic lesion, that's 2 by 1.9. We don't have an SUV on this, but no evidence of regional or distant metastatic disease. He gets a biopsy of his left upper lobe mass that's consistent with squamous cell carcinoma with necrosis. It's a poor sample, but the IHC lines up with squamous cells, positive for P40 and P63. We don't know the results of the left thyroid lesion or the right parotid lymph node. So we're still kind of trying to, in the workup stage, but the question on this case is, let's make a couple assumptions. Let's make an assumption that the left thyroid lesion and the right parotid lymph node are negative. Let's talk about potentially this still, so as I see it, this would be still a stage 3A/B lung cancer squamous cell. I assume, we don't have the images, but I assume that given the size of this, that this would be unresectable. But maybe I'll start with Dr. Lanuti. If this patient were in your office, and again, we don't have the images, can you walk us through how we would approach this case and whether they were surgically resectable or not? Is there a size cutoff? Or there's something on the imaging that tells you that this is not a surgery case?
Yeah, so a few things that I think stick out to this is the initial performance status of the patient being 2 and 3. Surgeons will often focus on that, and if someone can't ambulate very well, particularly after pulmonary resection, they often are high-risk surgical candidates. So that's one strike against this patient. You know, tumor size is not really always indicative of can it be resected. If this was a cavitary lesion that's in the left upper part of the lung that's adjacent to the ribs, I see that he has chest pain, so there might be chest wall invasion. That doesn't by itself mean it's unresectable. So really it's the workup of, is it, what stage is it? So in this case, assessing the mediastinal nodes, which I don't get a sense of that based on the description. I get the sense that there might be a PET-avid N1 node, but along those lines, I think the biggest part of this is that this patient with poor performance status probably might not make the muster of being a candidate for surgery.
Yeah, all good points, and specifically integrating the ECOG performance status in there as well, and the fitness level. Dr. Govindan, how would you approach this patient? This seems like if first of all, is there more workup needed in this case, even if the thyroid lesion and the parotid lymph node are negative? How would you approach this patient and work through making a therapeutic decision making for the patient?
Great. In terms of workup, two things. Brain MRI. Should we do brain MRI in these patients? So the yield of, in asymptomatic patients, there was a study published some years ago, and we looked at that as well. And SCC data set looking at how soon, within 3-4 months, they get brain radiation as a surrogate marker. About 8% may have brain metastasis at presentation, roughly in that region. So that's something to consider. But if somebody has a very poor performance status and asymptomatic, you're going to minimize your treatment risk. You can perfectly argue against looking for more disease in this situation. The second is, we do molecular analysis these days. Is there a point in doing it? In squamous cell lung cancer, we don't really find those traditional targetable alterations. 1 or 2 occasionally can pop up. For example, the TAC3 FGFR3 fusion, that can be quite helpful for targeted therapies, but only on a clinical trial. I don't see somebody with a performance status of 3 going on this. So only molecular marker in my mind that would make a big difference here is a PD-L1 status. If it is 50% or more, this is a perfect scenario where you could consider in terms of systemic therapy, if you're really going in that direction, pembrolizumab or single agent immunotherapy at that time. But coming back to, those are the reasons for workup I was going to argue for and against. In terms of therapy, I would ask my radiation oncology colleagues whether this would be amenable for radiation treatment. If it's predominantly localized disease, this person may be best served by radiation treatment. But if there is a reason to decrease the tumor size so that the radiation could be more tolerable, I would consider single agent chemotherapy or perhaps checkpoint blockade, pembrolizumab. The PD-L1 is 50% or more, and there are no contraindications for that. Completely not proven. We don't have level 1 evidence that this kind of a shrinkage and then the radiation will be appropriate. But I think it's on practical terms. I think that those are considerations from the systemic therapy point. If radiation can be done, I would favor that by itself, or perhaps after some in a sequential approach. I would avoid concurrent chemoradiation. If radiation is not possible, then I would say single agent chemotherapy, pembrolizumab if PD-L1 is 50% or more would be my choice.
You bring up great points here, all salient to how to manage this patient. Certainly this whole idea of induction treatment to get you to radiation, does that make radiation a more viable option? Dr. Curran, your thoughts on how to best manage a patient with an ECOG performance status of 2 or 3? Do we go with concurrent chemoradiation? Is it possible? What do you think about when you're thinking, when you're making this decision, or should we do sequential in some ways? How do you make decisions for this patient like this?
Yeah, thanks, Dr. Levy. I do agree with Dr. Govindan that this does not sound like a good patient for concurrent chemoradiation. this type of patient would not have been eligible for the trials that showed a value to that approach. I would try to, if assuming we're not sure he has metastatic disease, I would think about a hypofractionated regimen, you know, a 5 gray or 6 gray times 5 or 6, with the whole idea that you would actually be able to get in a highly conformal stereotactic-like manner, dose to the target and spare normal structures, especially esophagus and lung. And if the patient has mainly thoracic symptoms, the idea of doing that first and then follow that by either chemo or checkpoint inhibitor is an option. You know, the likelihood of a low PS patient responding to single agent chemotherapy enough to change the radiotherapy field is really unlikely. So I think we heard about thoracic symptoms, hit him with 2 weeks of hypofractionated radiation, and then consider systemic therapy as tolerated.
Thanks, Dr. Curran. Dr. Govindan, back to you. Just scenario, if this patient, if we decided to give this patient sequential chemotherapy followed by radiation, given the performance status, would you be okay giving durvalumab on the back end, a la the Pacific trial, even though that was with concurrent chemoradiation or induction followed by concurrent chemoradiation, if you didn't give immunotherapy up front?
You know, I think that's a great point, but I feel that you know, this durvalumab following concurrent chemoradiation is the perfect situation here. If you're not doing concurrent chemoradiation, you're not giving doublet therapy. I would, you know, if radiation can be given, I would simply watch this individual because, again, as Dr. Curran said, would this patient have qualified for the Pacific studies? The answer would be no. And here is somebody who did not get concurrent chemoradiation. I would just do radiation and watch, and then at the time of disease progression, I would give single agent therapy. What I think is important to keep in mind is that if somebody has a performance status of 3, you know, there is always this deflation of performance status in the clinical practice. If somebody is stated to be performance status of 3, it's probably worse, 2 to 3. And their comorbidities probably would dictate their duration of life. So I think it's important to keep the toxicities to the minimum. If radiation can be done, I would just simply watch this patient and do systemic therapy or consider systemic therapy only at the time of disease progression. So the answer to your question is no.
Okay, so let's wrap up here, and I may, you know, try to help calling you to summarize here because we played out a lot of different permutations of this. But is it safe to say that the current recommendations for this next steps in treatments would be A, to get a PD-L1, and if it were high, to consider some sort of induction immunotherapy, followed by potentially radiation. If it were low, consider a sequential chemotherapy followed by radiation or radiation alone. Is that a fair statement? Did I capture that correctly? Or if it were low, Dr. Govindan, you're saying you're not even sure you would give some sort of chemotherapy either as sequentially followed by radiation or even concurrently with radiation?
I think Dr. Curran answered my question. You know, I would only consider systemic therapy leading before radiation only if the radiation oncologist, you know, wanted the tumor to be shrunk. If the radiation oncologists are comfortable treating it, I would simply do radiation alone, watch, and then do systemic therapy only upon progression.
And in your mind, no ruled data for using durvalumab on the back end there. Wait,
Correct.
Potentially for systemic progression. Okay.